Hello everyone, today we'll speak about rheumatism or acute rheumatic fever in children. So, rheumatism is a broad term for inflammatory immune-mediated conditions affecting joints, heart, and other tissues. Acute rheumatic fever is a post-streptococcal inflammatory disease. It's a major cause for acquired heart disease in children in developing regions. The pathogenesis. So, first of all, you'll have immune-mediated inflammation triggered by infectious agents, commonly is group A Streptococcus. The molecular mimicry lead to a cross-reactivity between streptococcal antigens and the host tissues, and this will lead to a damage in the heart, joints, brain, and skin. Genetic and environmental factors. We can have some genetic predisposition that will lead to the pathogenesis or socio-economic factors. The pathogenesis of acute rheumatic fever. First of all, we have a trigger, untreated or inadequately treated Streptococcus pharyngitis, or an immune response antibodies generated against streptococcal proteins cross-react with, as we said, brain, skin, and other tissues. And the inflammatory cascade, we know in inflammation we have formation of cytokines that will lead to some inflammation issues and damage them, like we will have carditis, polyarthritis, arrhythmia, marginitum, and uh, cinnamon chorea. For the clinical symptoms and syndromes, we will follow a criteria called Jones criteria. So this is Jones criteria, sorry. We will need two major symptoms or one major and two minor symptoms to confirm the diagnosis of acute traumatic fever. And there must be an evidence of streptococcal infection in the history of the patient. So the major criteria are carditis, arthritis, subcutaneous nodules, erythema, marginatum, and Sydenham's chorea. The minors are fever, raised ESR, CRP, arthralgia, pain in the joint, prolonged PR interval in the ECG, and previous RF. So for the diagnostic evaluation, the lab test usually will have a high ESR and CRP. Streptococcal antibodies will be positive, ASO titer and anti-DNA SB. In the chest X-ray, we will see a cardiomegaly or pulmonary congestion in carditis. ECG will have, as we said, prolonged PR interval, probably arrhythmias and conduction abnormalities. And the echo, we will see if there is a valvular involvement, mitral aortic regurgitation, myocardial infarction, and pericardial effusion. So for we'll do a treatment approach for each patient. First of all, we will do a rapid treatment for the streptococcal infection if it's still present. Then we'll consider the age, severity of symptoms, and the presence of the complications to make adequate treatment. First of all, for the streptococcal infection, we will do benzathine penicillin. If the patient, the child, was more than 27 kilograms, we will give him 1.2 million units. And if he was less 600,000 units intramuscularly. The alternative is penicillin B orally, 250 milligrams, 2 to 3 times a day for 10 days. And then we'll do also an anti-inflammatory therapy. We'll give him an aspirin for the arthritis, 80 to 100 milligrams per kg divided to 4 doses, and corticosteroids for the carditis, 1 to 2 milligrams per kg per day. The complications, first of all, we will have valvular damage in the heart, a progressive valve stenosis or regurgitation leading to heart failure. Then we will have a potential for chronic heart failure and arrhythmias. We can have sediments chorea, and there's an increased risk of endocarditis and thromboembolic events. So the prognosis, the favorable prognosis, with early diagnosis and strict adherence to treatment and prophylaxis, many children recover without significant long-term damage. Risk factor for poor prognosis, such as severe initial carditis, recurrent episodes, and non-adherence to the treatment. They will do a monitoring and follow-up for the patients. That's actually everything. Thank you so much for watching. I hope you found this lecture useful. Uh, if you like the lecture, maybe let me know in the comments. Thank you so much. Have a great day. Goodbye.